This presentation explores a quality improvement project aimed at improving healthcare access in underserved and rural populations using mobile health clinics and community health worker outreach structured around the PICO framework. We will review the background and rationale for the Quality Improvement Project, explain the PICO framework guiding its design, outline the implementation plan, describe outcome measurement and data collection strategies, and finally discuss analysis results and the future directions. Understanding the healthcare disparities faced by underserved and rural populations is critical. We will explore barriers to accessing primary and preventative care and the importance of adopting innovative care delivery models to address these challenges. Addressing the critical issue of inadequate access to healthcare services. My goal is to advocate for expanded and equitable access to affordable medical, dental, mental health, and substance use treatment for all individuals regardless of their background or income level. This issue is urgent because health inequities harm not just individuals but entire communities. These disparities disproportionately affect BIPOC populations, low-income individuals, tribal nations, and rural communities, groups that already face the greatest systemic barriers to care. By advocating for comprehensive and inclusive healthcare solutions, I aim to help dismantle these barriers and promote a healthier, more just society for everyone. In rural communities often experience poor health outcomes due to limited resources, fewer healthcare providers, and socio-economical challenges. These disparities contribute to inequitable access to essential healthcare services. Geographic isolation, transportation difficulties, financial constraints, and lack of awareness about available services. These factors reduce utilization of preventative care and timely management of chronic diseases, such as mobile health clinics and community health worker outreach, can overcome traditional barriers by bringing care directly to communities, enhancing accessibility and engagement. Assessment was completed on Faribault and Martin County's Human Services to evaluate their capacity and readiness for participation in this quality improvement initiative. While Faribault and Martin County's Human Services is not currently affiliated with the project, the assessment demonstrates that they could be an active participant in future efforts to enhance healthcare access for underserved and rural populations. Human Services, or FMCHS, serves about 34,000 residents across 2 rural Minnesota counties. FMCHS provides a range of services including public health, financial assistance, child and family support, disability services, chemical dependency care, and foster care licensing. The agency operates offices in Fairmont and Blue Earth, relying on multiple state systems to manage and document services. Key challenges for FMCHS include limited staffing, workforce recruitment and retention, rising client complexity, and the logistical constraints of serving a large rural area. To address these, FMCHS assigns staff geographically to reduce travel and improve accessibility. Their performance improvement system is data-driven, using state platforms, and continuous workflow refinement. Leadership at FMCHS promotes the agency's mission and values through clear communication, regular staff engagement, and alignment with state and county priorities. Internal values such as integrity, equity, and respect are reinforced through supervision, training, and performance evaluations. External partnerships with schools, providers, law enforcement, and state agencies support coordinated service delivery. Strategic planning is collaborative and data-informed, involving supervisors, county boards, partners, and community feedback. FMCHS sets measurable goals aligned with state requirements, community assessments, and program trends. Action plans address workforce stability, documentation quality, compliance, and service access. Progress is monitored through key measures such as case timeliness, audit results, service utilization, and client feedback. Identifies its customers as community residents needing public health or human services. Market requirements are understood through demographic data, community assessments, program mandates, and partner feedback. Relationships are strengthened through accessible services, consistent communication, and personalized case management. Surveys and feedback loops support continuous improvement and innovation. Key organizational performance measures include case timeliness, service utilization, client satisfaction, compliance outcomes, workforce stability, and equitable access. Data from systems guide decision-making, inform training and resource allocation, and support innovation. Workforce capacity is assessed through performance evaluations, caseload analysis, staff input, and monitoring program demands. Staffing needs align with strategic priorities and anticipated regulatory changes. Workplace safety is supported through facility maintenance, safety protocols, emergency training, ergonomic adjustments, and strong data security measures. Mental health supports and open communication help maintain a healthy workforce environment. Work processes are designed through data review, staff engagement, and regulatory requirements. The agency uses technology, standardized procedures, and continuous feedback to improve efficiency and reduce variability. Improvement focus on equitable access, timely case processing, and coordinated community partnerships to strengthen outcomes. Aims to process at least 90% of SNAP and Medicaid applications within 30 days, achieve 85% positive customer feedback, complete all required annual training, and maintain expenditures within budget. Opportunities for improvement include workforce recruitment and retention, timeliness of benefit processing, and customer satisfaction, especially where staffing constraints impact service access and timeliness. Uses gap analysis, the PICO framework, to clearly define the population intervention comparator outcomes and timeline, ensuring a structured and focused quality improvement process. Improvement project identifies significant gaps in healthcare access for underserved and rural populations. The analysis highlights that best practices, such as community health worker outreach and mobile clinics, are not consistently implemented due to barriers like transportation, insurance coverage, and community engagement. Current practices rely heavily on traditional clinic-based care, which often fail to reach those most in need. The gap analysis table shows that while standard healthcare delivery is available, it is not always accessible or effective for populations facing socioeconomic, racial, or geographical barriers. Optional practices such as expanding Medicaid, and improving cultural trust are feasible but not widely adopted. This analysis concludes that addressing these gaps requires innovative solutions, including mobile health clinics and targeted outreach, to overcome barriers and improve health equity for vulnerable groups. Uses the PICO framework to guide its design and evaluation. The target population includes residents of underserved and rural communities who experience healthcare disparities due to socioeconomic, racial, ethnic, or geographic barriers. The intervention involves deploying mobile health clinics and community health work outreach to connect these residents with primary and preventative healthcare services. The comparison is with standard healthcare delivery, which relies on fixed clinics and self-initiated care seeking. The expected outcomes are increased utilization of primary care services, improved chronic disease management, and higher patient satisfaction with healthcare access. The project will be implemented and evaluated over a 12-month period to measure its impact on healthcare access and outcomes for vulnerable populations. includes individuals in underserved and rural areas facing socioeconomic disadvantages, racial and ethnic disparities, and geographic isolation, all of which impact health care access. Deploying mobile health clinics staffed with healthcare professionals and supported by community health workers who conduct outreach, education, and follow-up care within the community. Against the usual standard care, which relies on fixed location clinics that may be less accessible to the targeted populations. Statement and SMART goals. Project's aim is to improve healthcare access and outcomes for residents of underserved and rural communities. This achievement will be achieved by establishing a local health clinic and mobile health unit within 9 months. The goal is to increase patient reach by 20% and preventative screening rates by 15% within the first year of operation. SMART goals. Specific. Deliver primary care, preventative screenings, and health education through a local clinic and mobile unit. Measurable. Serve 20% more patients from underserved areas and boost preventative screening rates by 15% in 12 months. Achievable. Use community partnerships, grant funding, and collaboration with local providers for staffing and resources relevant. Directly address healthcare disparities by bringing services to those with limited access. Time-bound. Launch within 9 months and achieve measurable improvements within 12 months. Key drivers include access to care, workforce and staffing, community engagement and trust, infrastructures and resources, and quality and outcome measurements. Project identifies a diverse group of stakeholders essential for its successful implementation and sustainability. Key stakeholders include community members such as BIPOC, low-income, and rural residents who are direct beneficiaries of expanded healthcare services. Local and state health departments, clinics, hospitals, and mental health centers play a regulatory and operational role, supporting funding, oversight, and service delivery. Nonprofit or advocacy organizations and faith-based groups helped with outreach, education, and community engagement. Policymakers and legislators influence funding and policy alignment, while insurers and providers ensure coverage and reimbursement. Academic and public health researchers contribute to evaluation and evidence-based practice. Each stakeholder group is assessed for its level of influence and support, ranging from high to medium. Engagement strategies, including community outreach, joint planning, policy advocacy, partnership development, and tailored communication. By involving these stakeholders, the project aims to build trust, ensure cultural competence, and foster long-term sustainability in improving healthcare access for underserved populations. Considerations. Growing up and serving in rural Minnesota, I've seen firsthand the devastating consequences of healthcare inaccessibility. In Martin and Faribault counties, too many of our neighbors, our family members, coworkers, and friends are being left behind simply because they live too far from a doctor, a dentist, or mental health provider. It's not just inconvenient, it's unjust. The lack of access to affordable and comprehensive healthcare services is one of the most critical and preventable crises facing rural communities today. This issue is especially urgent in our counties, where health disparities are worsening outcomes for already vulnerable population. BIPOC individuals, low-income families, and those in isolated communities are the most impacted, yet often have the fewest resources to advocate for themselves. I'm calling on our state and local leaders to support the development of local health clinic and mobile health unit that can bring care directly to the people who need it the most. These aren't just luxuries, they are lifelines. A mobile unit staffed with nurses, nurse practitioners, mental health counselors, and addiction specialists could meet people where they are, literally and figuratively. Whether someone needs a routine physical, a dental checkup, mental health counseling, or substance use treatment, this model of care ensures that no one falls through the cracks. We know that when people delay care or forego it entirely, their health gets worse, their options shrink, and the cost to the community increases. But when care is accessible early and community-based, people thrive. Kids can focus on school, parents can stay healthy enough to work, our elders can age with dignity. As a future nurse practitioner, I believe deeply in preventative, holistic, and community-centered care. I also believe we have a moral and professional responsibility to eliminate the systemic barriers that perpetuate health inequities in rural Minnesota. This is a call to action for policymakers, healthcare systems, and community stakeholders to invest in solutions that reflect the dignity and worth of every person in Martin Faribault counties. Let's build a model of rural healthcare that leads with compassion, equity, and accessibility. Our communities deserve nothing less. Strategic deployment of mobile clinics and community health worker services, community engagement approaches, and a clear 12-month timeline with milestones for progress monitoring. The Local Health Clinic and Mobile Health Unit initiative aims to increase patient reach by 20%, raise preventative screening rates by 15%, and improve chronic disease management among underserved populations, with a focus on reducing healthcare disparities. The key drivers for success include improving access to care through flexible appointment options, strengthening workforce and staffing with targeted recruitment and incentives, building community engagement and trust with culturally competent outreach, enhancing infrastructure and resources, and using quality and outcome measurements to guide ongoing improvement. Strategic interventions range from expanding mobile clinic visits and partnering with local organizations to implement plan, do, study, act cycles for continuous refinement and tracking key metrics for accountability. Conditions, mapping a process and defining scope. The scope for the Quality Improvement Project. The process begins with the initiation of target communities experiencing healthcare disparities. It concludes with the implementation of process improvements based on evaluation outcomes at the end of the 12-month cycle. This clear start and stop points ensure that the project remains focused on addressing healthcare gaps in underserved populations and measures the impact of interventions over a defined period. The project focuses on enhancing access to primary and preventative health care for residents of underserved and rural communities. The initiative targets populations experiencing significant health disparities due to socioeconomic status, race or ethnicity, and geographic isolation. The project will deploy mobile health clinics in partnership with community health workers to deliver essential services, conduct screenings, and facilitate care navigation for those with limited access to traditional healthcare settings. Key stakeholders include patients, community members, local and state health departments, and healthcare providers. The intervention aims to increase primary care utilization, improve chronic disease management, and boost patient satisfaction. Exclusions for this project include residents already receiving regular care within hospital networks or suburban areas, as well as those needing specialized medical treatment beyond the scope of mobile clinics. The project will focus on the most vulnerable populations within the designated service regions, ensuring eligibility criteria are met throughout implementation. Implementation steps. A SIPOC diagram that outlines the process for implementing and evaluating mobile clinics with community health worker CHW support. The process begins with identifying target communities experiencing healthcare disparities and ends with implementing process improvements based on evaluation outcomes after a 12-month cycle. Key elements include suppliers such as public health departments, clinic staff, community partners, and data systems. Inputs such as funding, demographic and epidemiological data, equipment, and outreach materials. Process steps such as identify underserved communities, conduct needs assessments, plan schedules, deploy clinics and CHWs, provide care, facilitate follow-ups, collect and analyze data, and implement improvements. Outputs such as community priorities, needs assessment reports, operational schedules, and deliver healthcare services. Customers such as community residents, healthcare workers, and health officials. The SIPOC ensures all major contributors and beneficiaries are represented, providing transparency and accountability, and highlights the opportunities for identifying bottlenecks and areas for improvement throughout the initiative's implementation. Continues the SIPOC process by detailing the operational steps and outputs. Process steps including provide primary and preventative care services, facilitate follow-up and referrals, collect and analyze outcome data, and implement process improvements using the Plan, Do, Study, Act cycles. Outputs such as delivered healthcare services, completed referrals, follow-up documentation, performance reports, and improved processes. Customers such as patients, providers, healthcare partners, project leadership, and community stakeholders. The process concludes with the implementation of improvements based on the evaluation outcomes at the end of the 12-month cycle, ensuring the project remains focused on addressing healthcare gaps and measuring the impact of interventions that reflect the evidence with project measures team evaluation plan. It includes scheduling regular visits to underserved areas, integrating services with local providers, and ensuring culturally competent care through CHW involvement. Leaders, healthcare providers, and stakeholders is essential to foster trust, tailor services to community needs, and ensure sustainability of the intervention. Milestones such as initial deployment, midpoint assessments, and final evaluation, with ongoing monitoring to track implementation, fidelity, and outcomes. Methods used to measure key outcomes related to primary care utilization, chronic disease management, and patient satisfaction to evaluate the project's effectiveness. The measurement tools and evaluation strategies for the quality improvement project. The project tracks several key indicators to assess its impact. Mobile clinic utilization rate. This measures the percentage of the target population who receive care through mobile clinics within 12 months, aiming for at least 25% coverage. CHW follow-up rate. The project monitors how many patients receive follow-up care for community health workers, with the goal of achieving a follow-up rate of at least 90% within 30 days of clinic visits. Rate. This tracks the number of patients who continue with primary care provided by mobile clinics, aiming to increase the rate of compared to baseline data. Chronic disease management improvement rates. The project evaluates improvements in chronic disease indicators such as blood pressure and diabetes control, with a target of a 15% improvement within 12 months. Load and burnout rate. The project also monitors the number of community health workers reporting moderate to high burnout, aiming to maintain burnout rates below 20% throughout the year. Data is collected regularly throughout electronic health records, standardized tracking logs, and surveys. These measures help ensure the project's effectiveness, safety, and efficiency, and guide ongoing improvements to healthcare access and outcomes for underserved communities. On the frequency and timeliness of primary care visits within the target population to assess improvements in the healthcare access. Indicators such as blood pressure control, diabetes management metrics, and adherence to treatment plans will be tracked to evaluate chronic disease outcomes. Feedback will gauge satisfaction levels with healthcare access, quality of care, and the convenience of mobile clinic services. Action Plan, PDSA, Next cycle was sustainability plan. Next cycle in the quality improvement project focused on enhancing healthcare access and outcomes through mobile health clinic and community health worker CHW initiative. The main goals are to increase primary care utilization by 20%, improve chronic disease management indicators by 15%, and raise patient satisfaction with healthcare access by 20% among underserved and rural residents. In the plan phase, objectives include expanding access via mobile clinics, improving chronic disease management, and increasing patient satisfaction. Key data such as patient numbers, chronic disease control measures, satisfaction surveys, and follow-up rates are collected using mobile EHR systems and stored securely. During the do phase, mobile clinics deliver care and educate in targeted areas, with CHWs supporting outreach and follow-up. Data is collected in real time and uploaded to a central system with dashboards tracking progress and highlighting areas for improvement. In the study phase, data is analyzed to evaluate effectiveness using statistical and trend analysis, comparisons to baseline data, and geospatial mapping. Regular audits ensure data accuracy. In the ACT phase, results inform program adjustments or expansion. Successful strategies are scaled up, while less effective elements are revised. Ongoing monitoring ensures the program continues to meet community needs. Strong data management and analytics are emphasized throughout the PDSA cycle to set goals, track progress, and guide improvements, ultimately aiming to reduce healthcare disparities and improve outcomes for underserved communities. Will compare healthcare utilization, clinical outcomes, and patient satisfaction metrics between those served by mobile clinics and those receiving standard fixed clinic care. Results indicate improvements in access and disease management among participants receiving mobile clinic and CHW outreach, suggesting a positive effect on reducing disparities. Recommendations include expanding mobile clinic programs, increasing CHW training, and integrating these approaches into broader healthcare systems to enhance equity. Project demonstrates that mobile health clinics combined with community health worker outreach can effectively enhance healthcare access and outcomes in underserved and rural communities. Continued efforts and scaling are crucial to addressing long-standing disparities.